Institute in Canada, and hopefully soon in the States and other countries. But when we think about it, if I in the lab created creatine, I would be a billionaire, and it would be a drug, and we could call it whatever, because it was synthesized, which creatine is synthesized. But because it's naturally in your body and in meat products, people call it a nutraceutical. But it's the same thing. It has pharmacokinetics. It has, time to peak plasma levels. It has a pharmacological effect. And so, because we look at a molecule that may be present in nature and somehow think that it's inferior or it doesn't follow pharmacological principles is totally illogical. So I think of nutraceuticals as pharmaceuticals. And so we've coined this term, a nutropharmaceutical approach, which is what, we're doing certainly in our lab. And, we've got a spin-off company that's come out of this, where we use in vitro work, preclinical work, and randomized clinical trials with all of the pharmacological principles to prove efficacy and safety.
Yes. Yeah, we could spend hours on supplements, but
for sure.
So as we get older, in fact, potentially just because our diet is not excellent, we may be getting some deficiencies. Are there common deficiencies that you see in some of your patients, especially older ones?
Yeah.
And what would they be?
Yes, that's a great question, something we've been advocating for decades. So what we've done is we went back and looked at vitamin levels in over 1,200 of our patients. And what we found is 13% of our patients with genetic disorders had vitamin B12 deficiency. 4% had folic acid deficiency. When we first started, only about 15% had vitamin D deficiency, and that's severe. That's Ricketts range vitamin D, less than 30 nanomoles per liter. However, the current Canadian guidelines are 75 nanomoles per liter are required for optimal health. And when we use that metric, 85% of our patients were insufficient in vitamin D, but still around 15 to 20% were severely deficient, sort of in the Ricketts range. And something people forget is kids who have rickets also get a myopathy. And I've had many patients referred to me over the years who had, high muscle enzyme, muscle weakness, and fatigue. Everything was normal, but their vitamin D was almost non-detectable. We replace it, CK normalizes, and everything goes back to normal. So those we also see in the general population. Those are the most common deficiencies with aging. Vitamin D, critical. We just put every patient on at least 2,000 units. But ideally, what we do in our lab is we can measure vitamin D levels, and we replace to get people sufficient, which 2,000 units is usually sufficient. Number two, vitamin B12. People think, oh, it's just a vitamin, it doesn't do much, but it is the second most common cause of peripheral neuropathy in North America, vitamin D deficiency. And it can be insidious, and even low normal levels at the cell level can be dysfunctional. And you can get peripheral neuropathy, spasticity, spinal cord issues, and dementia with B12 deficiency, especially the older adult who's a tea and toaster, we call it, without a wide variety of fruits and vegetables and green leafy vegetables. They may well be vitamin B12 deficient, and or you don't absorb it through something called pernicious anemia. So check your vitamin B12 levels yearly and replace if they're in the low normal range. Vitamin D, if you can, get it checked and replaced to get it normal, and or just take 2,000 units a day. Every couple of years, it'd be reasonable to check folate because we've had a few people who've actually gone blind from folate deficiency as they were older with low folate. Now that's very rare, but to get a folate done every couple of years is probably not imprudent. The other thing that we find pretty much across the age range, right from teenage athletes all the way up, are females are more likely to be hypoferritinemic, meaning they have low iron stores. And traditionally people say, well, look, don't worry about it unless you become anemic. However, there's been some good work in animals that if you have low ferritin levels, which reflect low iron stores, it can affect the iron sulfur clusters of the mitochondria, and you can have fatigue and weakness as a consequence of that. And so we generally would suggest getting your ferritin levels over 50 especially for women. And a study in Canada years ago showed that postmenopausal women with chronic fatigue, if they had low ferritin, getting it over 50 improved their symptoms significantly. So those are the things that I would recommend people should be checking, especially as we get older, as those deficiency rates become more common.